Morning. Welcome to Seifeld. This morning's discussion will focus on the episode, the junk mail. So, your last day here, or the clerk's last day here. Who wants to start in terms of their observations on the junk mail?
George.
Just starting out the episode with his seemingly long-time concern or obsession with Jerry's summer, George. And how this kind of plays throughout the episode. I feel like it just really illustrates his continued desire for control in every situation. Like, if he's not the center, if he's not kind of like fully, has control of the situation, he just gets very insecure very quickly. And I feel like this plays out with both the summer George, but also with his parents too, where if he doesn't, when he realizes that in preparation for his call with them, he's trying to like set up the thing like, oh, like, they're the ones who are concerned about me, but then it flips and he realizes, oh, they have no concern. He gets very upset, even though in the beginning he seems he would have seemed fine with that apparently, but I feel like with both dynamics it just illustrates his continued desire for control, desire to be the center of the situation.
Yeah. So let's talk about this. Because you mentioned at least 3 or 4 things that I think actually tie together very nicely for someone who's trying to formulate this observation. And we're focusing now on George. Number one, you used the word obsession. So let's make sure we delineate this term. Obsession is a deficit in thought content. Other deficits would include the overvalued idea, preoccupations, ruminations, and even delusions. Right. So those are the 4 or so common deficits that often come up in exams, clinical practice, when we focus on thought content. The overvalued idea, aka the superstition, arbitrarily and somewhat universally is considered to not cause any clinically significant impact on our behavior or functioning. Right? So it's not clinically significant. So if an individual appears to be overly focused on something, and in your clinical opinion, it does not result in clinically significant distress or impairment in functioning, we're going to label that an overvalued idea. If it does, that is, if it is clinically impactful, we're going to move away from that term, and now there are several other terms. For all intents and purposes, especially for an M3, the preoccupation, the obsession, even rumination, somewhat interchangeable. Now, I think for residents in training, certainly faculty, there are things you need to consider to tease out one from the other, but for shelf exam purposes, preoccupation, obsession, rumination, all the same. And we'll say they're intermediate. That is, they're clearly not as severe as a delusion, and I'm going to tell you why in just a second, but they are more severe than the overvalued idea, in as much as that they do result in clinically significant distress or impairment in functioning. Where the delusion separates from all of the above, these intermediate deficits, is that not only similar or shared with the others is it not reality-based, but more importantly, it is rigid. Right? That is, the individual will not demonstrate insight as to the nature of their fixed belief. Right? So it's rigid. And that rigidity, that lack of insight, really differentiates it from the rumination, the obsession, even compulsion. The preoccupation. Yeah.
When you said lack of insight, so do you specifically mean that this person is an delusional person? Obviously, they don't accept facts when they come to their conclusion. They don't realize that they're fixed. Is that what you mean? Versus like someone who's like political and they're like, I'm only voting this way, no matter what. That's like, okay, so that's what you mean?
Yeah.
Okay.
And I think clinicians rarely will be direct with this, but at some point in the conversation or psychiatric evaluation, you have to probe insight. Do you really believe that CIA has tapped your phone? When there's no evidence to that and your spouse is looking at me like, right? If the individual is fixed, you can just imagine the reaction you're going to get. You might be one of them. The individual who is able to say, I know it sounds crazy, Doc,
Okay.
but I just can't get this thought out of my head, is giving you some insight. And it's not always that easy, but those are the 2 things you have to look at, one versus the other. Insight, we're going to say it's intermediate. It might be a preoccupation versus an obsession. that profound lack of insight lends to rigidity, the fixed belief, and we're going to call that a delusion. The theme could be exactly the same. I was abducted last night by aliens, right? And it was Halloween. They were wearing masks, human masks. Nobody's getting that right. That's no November 1 humor. No. I digress. All right, so let's start there with George. He has an obsession, right? He's got this maladaptive and therefore clinically significant deficit in thought content, yet I don't think he's delusional, right? Now, we also heard that he has this sense of control, and this sense of control likely stems from insecurity, and then insecurity itself likely stems from early childhood experiences. I heard you mention his parents. So those align very nicely. But let's talk about George's need for control and where this comes from. I do not believe George is afflicted with the obsessive compulsive personality disorder. I don't. But individuals who have this overbearing need for control, perfectionism, and order are certainly have the cardinal trait of OCPD. Right? This is the type A personality. There's nothing wrong with type A traits. Right? I'm speaking to the table. However, when those traits constellate, are pervasive, there's that P word again, and cause clinically significant distress or impairment, then a disorder needs to be evaluated, and the most likely disorder on a shelf exam would be obsessive compulsive personality. OCPD, that personality disorder, in no part of its definition names or mentions obsessions or even compulsions for that matter. So it's a bit of a misnomer. That said, the reason why it's actually named similar to obsessive compulsive disorder, the individual who has clinically significant obsessions and or compulsions, is because of overlapping signs and symptoms, right? So it does tend to confuse on exams, but for the most part, the perfectionist is OCPD. The individual with obsessions and or compulsions that are clinically significant have OCD, right? So that's where the control comes in, and that's where the control, the need for control, is paired, linked to the obsession. The obsession defines OCD, the control defines OCPD, and because these two separate conditions may have overlapping and similar third variable type etiologies, they're named similarly, right? And that etiology is going to be early childhood experiences, or at least related to, and you did bring up insecurity related to his parents, right? So it does all come together. See, it's true. Any other observations or questions about George, OCPD, or obsessive compulsive disorder?
He's able to go to like great lengths to keep control. For example, he like was willing to date his cousin, and it wasn't like
Yeah. The especially for anxiety disorders, when we look at clinical impairment, that could be both qualitatively and quantitatively. So qualitatively is pretty straightforward, right? And what you just said seems to be impairing, right? However, even if it wasn't, let's say either it's culturally sanctioned or it was just his trying to date another woman who is not going to be approved of, that is not related. Qualitatively, you're like, quantitatively, if there's time spent that is excessive, you could still rule in clinical significance, right? So both qualitative as well as quantitative. In this case, I don't think anybody's going to argue or further need to discuss the qualitative element of his trying to date his cousin. Again, excessive time spent is a quantitative metric for clinical significance as well, especially with the anxiety disorders. Other characters that caught your eye?
I don't know her name, but
Elaine.
Thank you, Elaine. Yes,
It's been 5 weeks.
She's yeah, I know it's bad. I keep forgetting her name. I don't know the main character's name either. I do know Kramer and George though. What's her? Yeah, so it seems like she's like, especially with the last episode, it seems like she's very superficial in that like she just sees the guy and instantly falls in love with him, which is like a trait of borderline. But then like I guess she's not borderline because as soon as the guy put on the hat, she stopped liking him. So borderline's like more fixed, right, with splitting. Yes, no.
Yeah, we could see some unstable relationships from borderline, certainly. Yeah.
Oh, okay, then, well, yeah, like, it is unstable. She, like, broke up with her boyfriend instantly off of how a guy looked. So, and then on top of that, the previous episode, when she fell in love with well, she didn't fall in love with him, but she's, like, pursued the main character because he had, like, a little extra money. And it's, like, this common theme with her, which is very superficial reasons to pursue romantic relationships.
Mm-hmm. Mm-hmm.
I don't watch the show, so I don't know how she got with her boyfriend. I'm sure that was also superficial or humorous, the original guy, but that's like a theme I'm noticing with her.
Yeah, yeah. I mean, there's even web pages and websites dedicated to Elaine Bendis' boyfriends. So I think it's very fair to say that she demonstrates a pattern of unstable relationships. We don't get the prequel. I think her father is in 2 episodes, maybe 3. In each, he is an overbearing character. He is, even though he's a peripheral character, again, only 2 or 3 episodes total, that's 9 seasons. When he is in an episode, he is a big part of the plot. And that includes Elaine's perception of him as a father. He's very cold, domineering, certainly unnurturing. And I don't think, even though she does mention a sister, I believe, who lives in St. Louis, I don't think she mentions her mother a single time. I think there's a picture of Elaine's mother in the background once, but beyond that, no mention of that character. So you could, and all this means is that as a clinician, if we were presented similar information during a psychiatric evaluation, we'd know we'd have to inquire. So the idea of watching this and treating 9 seasons, or at least a selected episode, The Junk Mail, as a fictional case, here we are, really inquiring. There's something going on here that probably needs investigated as to what is impacting her adult behavior, specifically her unstable relationships.
I just want to make a quick point that very briefly in the episode, as we all saw, Elaine instantly falls in love with these dreamy eyes or this image of this guy. But when Jerry meets him as well, he does the same thing. And that's to speak of the superficiality of his relationships as well. So it's not just Elaine, it's also Jerry.
Yeah, when I saw that, I wasn't sure if that took away from Elaine's superficiality. I'm thinking, maybe this guy is so attractive that everyone just loves him. But I didn't know that Jerry's also similar. So you just have 2 people who are the same boat.
Right.
Yeah. Jerry is just as superficial. Jerry has a girlfriend in every episode, if not, and if not every other episode. There's, I think it'll be very easy to kind of go down this rabbit hole and talk about his adult relationship as well. As a matter of fact, we even talked about it. Was it last week or the week before that he and George had made a pact, and that pact stems from the insecurity he has with dating women. It was him at Monks that said, "What are we? We're children. We have to change." So yes, and there's been more than one episode that has certainly been influenced by Jerry's superficiality as well. Other observations: The Junk Mail. We're about halfway through. We got about 5 or 10 minutes left.
Jerry's friend.
Who's that?
Oh yeah.
I can't remember his
Fragile.
No.
Fragile Frankie.
Fragile Frankie.
Frankie.
Yeah.
Yeah.
I mean, who runs into the woods and digs a hole
To die in.
Right, he sits in a hole.
whenever he's his armor is slightly pierced.
Mm-hmm.
Definitely notable.
What's going on there?
I'm not quite sure.
That's what I mean.
Oh, I was gonna say, like, when I first watched it, like, because they said that he had been like that, like, from a young age. It almost reminds me of, like, I'm not saying, like, I would diagnose him with it necessarily, but, like, avoidant personality disorder, because it seems like he does want, like, connections with people. That's why he gave Jerry the card, but he's very, like, fearful of rejection and shame.
Yeah. I think it's a very fair initial assessment. I think we're looking at avoidance behavior, and we're looking at clinically significant avoidance behavior, and then we could develop a differential from there. And avoidant personality, given its onset, when we know that it happens. Yeah, I think that's part of the discussion here, definitely. The other thing to consider, again, I do very little child health, child adolescent psychiatry. But if, I don't know how they would do this, but if this character was 18 months of age, one of the things that pops up is separation anxiety.
Yeah.
And the reason why I bring it up is because, not necessarily that it fits the plot perfectly here, far from it, but it comes up on exams. And since, and I'm always confused as to when clerks take exams these days because of the
Next month.
525, 516, whatever it is, next few days. It's always important to review this stuff. When anxiety disorders or an anxiety disorder vignette appears to present on a shelf, on a standardized exam, very often choice A is normal behavior, right? And so it's very, very important to know your developmental milestones. Separation anxiety peaks at 18 months of age. Hopefully the question writer will not put a 19-month-old or even a 2-year-old on the exam. If they're going to keep it focused on it as a child, it's a red flag. Hopefully it's 9 or 10 or 11 years old, far enough from 18 months for you to actually identify that it's developmentally inappropriate. Right? So I just want to make that comment, not necessarily that it fits here, but that's where the conversation starts. This is normal behavior. For our particular character, the answer is no. There's something going on here. It's certainly developmentally inappropriate for an adult to avoid like this and go and dig a hole to sit in. And I think since its onset does appear to be in early childhood or childhood, the idea of an avoidant personality disorder, especially since he does want relationships, which would differentiate it from schizoid personality, is going to be high in our differential diagnosis here. Even though this doesn't fit any Seinfeld episode, any film in which somebody does something maladaptive with a hole, I'm thinking bipolar. Right? And it's only because your acronym is DIGFAST. Right? So if this guy's digging a hole, I have to investigate this, if not to just review the diagnostic criteria for me. Yeah. Now, if you've seen Creep, it fits really well, because I really do think that main character has bipolar 1. And maybe not so much in the first, but the sequel, which is just as good. He does dig a hole, but no spoilers. Right, so sometimes it works, doesn't really work here. I'm not sure why mania would result in avoidance behavior. It doesn't really fit there. But certainly the anxiety disorders and a differential diagnosis, something that clinically significant anxiety, avoidance behavior in particular, would be the focus of clinical attention. 3 minutes. Should we go into the differential of mania versus hypomania one last time? Just to make sure we get these clinical terms down?
Yes, sir.
So if an individual has established mania, give me 4 conditions in your differential diagnosis. So somebody comes in who meets clinical criteria for DIGFAST.
Bipolar 1.
Schizoaffective.
I'll give you that one. Right?
Okay.
Bipolar type, right?
Yeah.
I read your mind. I knew that's what you meant. 2. By the way, that is the only other mental disorder that it could be other than bipolar 1. And that's a hint.
Cocaine intoxication?
Yeah. Substance-induced mania, substance-induced bipolar disorder. And what's the cousin to the substance-induced?
Medication.
Oh, medicine.
Well, medication's the same.
Yeah.
Medical.
Oh, those are medical condition. Oh.
Yeah. Yeah. So bipolar disorder due to an underlying or another medical condition. That's just a 4-part differential, right? So let's say the other 3 are ruled out, and this is straightforward mania that is not in the context of schizoaffective disorder. Differentiate for me this condition, this syndrome, from hypomania.
Mania versus hypomania. Mania has results in like a hospitalization, I believe, or this is for bipolar, but like psychosis, I know would like put you in bipolar 1 versus bipolar 2. I think it also like the duration of the mania decides whether it's hypo versus regular mania. I'm not sure the time frame, but I think it's like like over a week or like but a couple days for hypomania.
At least 4 days for hypomania.
Yeah, and then it's just like, literally the significance of your behavior, the severity of what you do. And hypomania is going to be less severe. I don't know how to articulate that.
The words we use are clinically significant.
Not clinically significant.
That's it, right? So we have, again, both qualitative and quantitative metrics here. Qualitative, If the behavior is clinically significant, we call it mania. If it's not, we call it hypomania. Quantitative, 1 week. If it's a week or more, we call it mania. If it's less than a week, but at least 4 days, we call it hypomania.
But even if it's longer than a week, but not impacting the person severely on a day-to-day basis, but just because the duration's longer, you'd still call it mania?
I think that is to the discretion of the clinician. To my knowledge, you have to meet both criteria to call it hypomania. It's going to be less than a week and not clinically significant.
Okay.
Yeah.
Interesting.
When mania alternates with episodes of major depressive disorder, what is the single best answer? When hypomania alternates with episodes of major depressive disorder, what do we call it?
Cyclopenia.
Two. So, and then the final question is, how do you differentiate bipolar 2 from cyclothymia or cyclothymic disorder?
Time, I believe, to like 2 years is cyclothymic.
Yeah. And?
Those episodes for mood are only to minor depression to hypomania.
Right? Right. So in both cases, hypomania is alternating with depressed mood states. The depressed mood state that defines bipolar 2 is major depressive disorder, while the depressed mood state that defines cyclothymic disorder is minor depression. Right. So again, a major depressive episode, I'm loose on the term major, a depressive episode that again does not meet 7 days and is not clinically significant.
So is cyclothymic.
I'm sorry, 2 weeks. I meant 2 weeks.
Okay.
So is cyclothymic disorder just a lesser degree of hypomania in
No.
terms of the symptoms?
No, hypomania. No, hypomania is the same.
Okay.
The major depressive episode is what we focus on clinically that differentiates these two syndromes,
Okay.
right?
Yeah.
In bipolar 2, it's a major depressive episode, right? It's SIGI caps over 2 weeks that is clinically significant. When you have SIGI caps that is less than 2 weeks and is not clinically significant, we often refer to that as minor depression. And when minor depressive episodes alternate with hypomania, we call that cyclothymic disorder. Okay. And then the last part of that definition is, and all of the above is for at least 2 years. Right? Questions about the bipolar and related disorders? By the way, so we're going to end it here, but I have to end it with a little bit of a teaser. Did anybody notice that when watching the film we're going to discuss at noon today, this entity actually gets you at a week? And there's a comment that some people don't even last 4 days. I just thought it was really insightful that the 4-day and 7-day windows are part of this entity's emergence too. So just a little bit of a teaser as to what this movie may be really about. We're going to end it here. For the folks at home, we're going to log right back on for morning round. So we'll see you on the other side.